Okay, in this final lecture we're going to talk about SHAVED, which are 6 high mortality conditions that need to be managed promptly in order to optimize your patient's survival. In this slide we can see several instances by which we may consider a SHAVED criteria. There's some hemorrhage, IV drug overdose, anaphylaxis, epilepsy, hypoglycemia, and a VF arrest. So these are situations which you might be considering whilst you're performing a good assessment and management of the doctor's ABCD structured approach. So whilst you are assessing the patient, managing their airway, then breathing, then circulation, these 6 criteria are in the back of your mind in case any one of these is causing the patient to remain unwell and needs prompt treatment. We'll go through them each in turn. So first we have consideration of sugar, or primarily hypoglycemia. The patient may appear sweaty, confused, tachycardic, or even having a seizure. One particularly needs to think about this in children who have a small amount of reserve, or in patients who may be diabetic and on insulin. Once a blood sugar has been performed and hypoglycemia has been diagnosed, in an adult it's ideal to give 50 ml of 50% glucose IV into a large cannula into a large vein. In children it's a 10% glucose solution at 5 ml per kilogram. In the doctor's order bag and the emergency doctor's drugs we have IM glucagon 1 mg, which may be of use if you don't have access to IV glucose. Remember, in a patient who has a seizure, it's important to check their blood sugar, especially if they have recurrent seizures, as hypoglycemia may be the cause. Okay, hemorrhage. You need to be aware and looking for signs of massive arterial bleeding. That may be coming from an external source, in which case it's usually fairly obvious to see once you expose the patient. But remember, in certain situations, especially in obstetric and gynecological situations, there can be internal bleeding, which may not immediately make itself apparent. The patient may have hypotension, tachycardia, altered conscious state, and there may be signs of bleeding. It's important when managing bleeding to splint long bone fractures, put compression of the bleeding, and have the patient access a surgeon as soon as possible. A tourniquet may be appropriate. Once the source of the bleeding has been stemmed as best you can, you need good structured approach, doctor's ABC, 2 14 gauge IV cannulas, blood products early, 20 mg per kilogram fluid bolus, and cross-match blood as soon as possible. O negative may be essential in these situations. Anaphylaxis. The first symptoms of anaphylaxis is usually the patient telling you they feel very faint and terrible. Hypotension shortly follows. Patient often looks very pale. There can be, but not always, a tachycardia. There may be airway involvement with wheeze and stridor, and there may be signs of angioedema and rash, although these can be late. The management of anaphylaxis is doctor's ABC, with early use of adrenaline, 0.5 mg IM, or 0.1 ml of 1 in 10,000 for children. We'll look at mixing up adrenaline in the practical day. The patient needs to be monitored very closely. Good quality doctor's ABC. You may have to repeat the adrenaline in a few minutes if there's no sign of response, and then one can consider antihistamines and steroids further down the line. Here's a chart showing the doses of anaphylaxis that's used at the Royal Children's Hospital in Melbourne. In adults it's 5 ml of 1 in 10,000, which is 500 micrograms or half a milligram. In children more than 12, they're considered adults, they get the same dose. In children 6 to 12 years old, they get 3 ml of the solution. In a child less than 6 years, they get 1.5 ml. This can be repeated at 5-minute intervals or even sooner if there's poor response. Okay, the VF or VT arrest. The patient is usually unconscious. There are a few instances of a conscious VT, but that is not a rhythm which is sustainable with life and will need prompt treatment. The precordial thump delivers a very small amount of energy to the heart, maybe 6 or 8 joules, and is generally not recommended if you can get access to a defibrillator as soon as possible. I would forget the precordial thump and call for a defibrillator as soon as you can. You need good quality CPR, follow the advanced life support algorithm, and the management for VF or VT is electricity, which comes in the form of defibrillator. That's been covered in the last lecture. Epilepsy or sustained seizure activity. The definition of status is if the patient has had a seizure for greater than 30 minutes or is getting repeated seizures with loss of consciousness despite your management. You need good quality doctors ABCD. You need to exclude hypoglycemia. IV access can be very difficult, so I would recommend using IM midazolam 0.1 milligrams per kilogram, which can be repeated at 5 minutes if there's no response. These patients can be very unwell. You will need expert advice and anesthetic help with these patients. You may be using IV phenytoin or other agents, but that would be under consultation with a tertiary hospital. Finally, we have drugs, mainly narcotic overdose. Consider this in patients who have signs of IV tract marks and a changing level of consciousness. The presentation can be delayed. They can be conscious on arrival to the department or conscious on presentation, and then their level of consciousness can deteriorate over a period of minutes. They will get to the stage where their conscious state is pain or unresponsive, so P or U on the AVPU scale, or a GCS of less than 8. At this point, one might consider management of their airway, and the treatment is good quality doctors ABC, maintaining their airway and reversing their narcotic hypnosis with naloxone 800 micrograms IV. Be cautious with naloxone. It often proves to have a very rapid and prompt response, and that can wear off over the next 15 to 20 minutes, so the patient needs to be monitored very carefully. Okay, thank you very much.